The iTotal G2 Cruciate Retaining Total Knee Replacement System is a patient-specific tri-compartmental knee replacement system composed of personalized implants and disposable instrumentation. The product design incorporates a bone-preserving approach for the treatment of severe pain and/or disability of a knee damaged by osteoarthritis or trauma. By utilizing proprietary iFit image-to-implant technology and data from a patient's CT scan, implants are personalized for each patient. This personalized approach enables a fit so precise that it eliminates the sizing compromises common with traditional total knee replacements. The implant is designed to restore the natural articulating geometry of the knee. The accompanying patient-specific disposable iJig instrumentation is employed in the following 5 steps. 1. Distal femoral resection. 2. Tibial resection. 3. Femoral preparation. 4. Tibial preparation. 5. Trialing and cementing implants. Every iTotal G2 system ships with a set of iView patient-specific planning images. The iView images provide information on bone resection and distal femoral implant offset values, as well as positioning information for the implants and iJigs. Step 1. Distal femoral resection. Position the patient on an operating table with the leg resting on a foot support at approximately 90 degrees of flexion. After a short midline skin incision, perform an arthrotomy. Place the femoral positioning iJig F1 on the femur so it finds its natural conforming location. This iJig is designed to reference osteophytes and will secure firmly onto the femur. The anterior referencing feature of F1 will sit on subchondral bone. There may be some space between the iJig and femur where there has been cartilage loss. The femoral iJigs have been designed to fit over 3 millimeters of cartilage. Next, create 2 cartilage voids on the distal femur by inserting the coring tool through the holes of the F1 iJig. Apply axial pressure until the cartilage is removed, but before the coring tool advances into subchondral bone. Using a curette, remove any residual cartilage within the cored holes. Attach the distal femoral cut guide, F3, to the femoral alignment jig, F2, by connecting it to the mating feature on the anterior portion of F2. Position the iJig assembly so it sits flush against the femur and the 2 dimples on the undersurface of F2 seat into the cartilage voids created by the coring tool. The patient-specific surface of F3 will conform to the anterior femur. There may be some space between the iJig and femur where there has been cartilage loss. Drill through the anterior pinholes of F3 and insert 2 Steinmann pins. Drill through the 2 distal holes of F2. These holes will be used during femoral preparation for the placement of the AP cut guide. Remove the F2 iJig. The F3 iJig has a patient-specific surface that extends over the trochlea and a step on the cut surface consistent with the distal femoral offset. In cases where the distal femoral offset is less than 2 millimeters, the distal cut will either be a 2 millimeter step cut or a flat cut, depending on which option preserves the most bone. Begin by placing the reciprocating saw blade along the step on the distal cut guide and create a transition cut. Next, using the oscillating saw, make the distal condylar medial and lateral cuts. Place the extension spacer block T2 onto the cut distal femur to confirm the cuts are planar. If T2 does not sit flat, revisit the cuts as needed. +2 and -2 F3 cut guides are also provided. The +2 cut guide is available in the event an additional 2 millimeters needs to be resected from the distal femur, and the -2 cut guide is available to reduce the initial distal resection by 2 millimeters. Remove the 2 Steinmann pins and the distal cut guide. Step 2. Tibial resection. With the leg in flexion, place the T1 tibial iJig flush against the anterior tibia. The inner surface of the iJig is patient-specific and will conform to the proper location. The 2 projections of the T1 iJig sit on the anterior proximal tibial plateau and conform to the subchondral bone surface. Using a surgical marker, outline the profile of T1 on the proximal tibial plateau. Remove the T1 iJig. Using a scalpel or curette, remove any residual cartilage or tissue anterior to the marked line on the proximal tibia. Next, place T1 back into position on the tibia. T1 will feel secure in its final position. Verify axial alignment by attaching an alignment rod to the distal end of T1. The alignment rod should line up parallel to the tibial prominence and the center of the malleoli. In the sagittal plane, the alignment rod should be parallel to the tibia. If the alignment or slope is not correct, adjust the position of T1. Drill and pin T1 into place through the 2 anterior pinholes and the medial stabilization hole. 3 ancillary tibial cut blocks are provided and use the same pinholes as T1. A 0 uncaptured cut block, a -2 cut block which will raise the cut plane by 2 mm, and a +2 cut block that will remove an additional 2 mm of bone. The planned resection is 2 mm below the lowest point on the medial tibial plateau. Using the captured cut slot of the T1 I-jig, resect the proximal tibia while taking care to preserve the posterior cruciate ligament. Remove the Steinmann pins and the T1 I-jig. Step 3. Femoral preparation. Remove all peripheral tibial and femoral osteophytes. Prior to balancing the knee, all osteophytes tensioning the soft tissue need to be removed. With the knee in extension, place the extension spacer block, T2, between the cut distal femur and the cut proximal tibia. Assess the knee for appropriate balance by applying a valgus and varus stress. The T2 I-jig has 2 mating holes for attachment of alignment rods to assess knee alignment and extension. Attach an alignment rod to the anterior hole on T2, pointing proximally towards the femoral head, and an alignment rod to the posterior hole, pointing distally towards the center of the malleoli, and assess the alignment of the knee. Bring the knee into 95 degrees of flexion. Then place the flexion spacer block, T3, on the cut tibial plateau. The condyles should sit posteriorly on the flexion spacer block. Assess the knee for appropriate balance by applying a valgus and varus stress. 2 mm and 3 mm shims are provided with the system in the event there has been posterior condylar cartilage loss. If the knee is appropriately balanced and aligned, proceed to final femoral preparation. If the knee is tight in extension and flexion, resect an additional 2 mm from the tibia using the +2 tibial cut block. If the knee is tight in extension and balanced in flexion, resect an additional 2 mm from the distal femur using the +2 distal cut guide. If the knee is tight in flexion and balanced in extension, add slope to the proximal tibia. Place 2 Steinmann pins in the holes on the distal femur. Slide the AP cut guide, F4, over the Steinmann pins. F4 will be centered on the cut distal femur, and the medial profile of the guide will match the medial profile of the cut distal femur. The AP cut guide should not overhang the cut distal femur medially or laterally. The lateral slot on F4 allows the guide to rotate about the medial pin. This allows adjustment of up to 5 degrees external rotation. Using the provided patient-specific angel wing, confirm the trajectory of the anterior cut will not notch the femur. Drill and pin the AP cut guide in place through the 2 stabilization holes and remove the initial 2 Steinmann pins. Make the anterior resection using the top flat surface of F4. Then make the posterior resections through the medial and lateral captured slots. Make the anterior chamfer resection through the captured slot. Next, drill the 2 implant peg holes. Remove the 2 Steinmann pins and the AP cut guide. Place the first posterior chamfer cut guide, F5, on the distal femoral cut such that the pegs fit into the holes on the distal femur. Impact the guide securely into place using a mallet. The letters A and T are marked on the anterior surface of the cut guide. Make the chamfer cuts using the 2 flat surfaces of the I-jig. The I-jig can be stabilized using the handles on the medial and lateral edges or the anterior stabilization pinholes using Steinmann pins. Remove F5 and replace it with the second chamfer cut guide, F6. Impact the guide securely into place using a mallet. The F6 I-jig can also be stabilized using the handles on the medial and lateral edges or the anterior stabilization pinholes using Steinmann pins. Make the second set of chamfer cuts using the 2 flat surfaces on the I-jig. Remove F6. Assemble the femoral impactor tip onto the impactor head by connecting the mating surfaces. Assemble the femoral impactor head onto the impactor handle by connecting the two pieces at the mating surfaces. Place the femoral trial F7 on the femur and impact into place. The femoral implant can be used for trialing in place of F7 if desired. Visually inspect for and remove osteophytes and bone in the transition area between the femoral trial and the posterior condyles. This is important for achieving increased flexion. Step 4. Tibial preparation. Confirm peripheral tibial osteophytes have been removed and place the tibial template T4 on the cut proximal tibial plateau. Line up the arrow on the front of the tibial template with the medial 1/3 of the tibial tubercle. T4 should be positioned for optimal plateau coverage while keeping to the posterolateral tibial corner. T4 also functions as a tibial trial, with two thicknesses provided that match the thickness of the tray with 6 mm medial and A lateral poly inserts, or 8 mm medial and C lateral poly inserts. Bring the leg through the range of motion, assessing stability and balance. If the knee is properly balanced, pin the tibial template in place using the tack pins. A T5 tibial template option is also provided with a thinner profile in the event T4 does not easily fit into the joint space. The size of the stem drill bit and keel punch will be indicated on the handle of the tibial template. The three sizes are 10, 12, or 14 mm. Place the tibial drill guide into the T4 eye jig and be sure the guide seats flush for the proper drill angle and depth. Prepare the tibial stem hole using the indicated size drill bit through the drill guide to the hard stop. Remove the drill guide and assemble the keel punch tip onto the impactor head by connecting the mating surfaces and turning the handle clockwise to lock into place. Use the indicated size keel punch through the slot on the tibial template to complete tibial preparation. Step 5. Trialing and cementing implants. Insert the tibial tray followed by the A lateral trial poly and then the 6 mm medial trial poly to evaluate kinematics and ligament balancing of the knee throughout the range of motion. Additional poly trials are available to facilitate proper balancing of the knee as needed. 7 and 8 mm medial and B and C lateral trials are available. The A lateral trial measures 6 mm plus the distal femoral implant offset, and the B and C trials increase by 1 mm in thickness respectively. The distal femoral implant offset value is provided on the iView patient-specific planning images. Assemble the femoral impactor head onto the impactor handle. Then place the femoral trial F7 on the femur and impact into place. The femoral implant can be used for trialing in place of the femoral trial if desired. Evaluate kinematics and ligament balancing throughout the range of motion. Use thicker medial or lateral trial inserts to achieve desired balancing and alignment. In the event soft tissue balance or joint alignment cannot be achieved, ligament balancing using standard soft tissue releases may be considered. Remove trials and tibial tray. Then irrigate the joint in preparation for cementing the implants. Apply a layer of cement to the tibial tray and the tibia, filling holes and covering the bone surface. Assemble the tibial impactor tip onto the impactor handle and impact the tibial tray into place. Remove any residual extruded cement from around the implant with consideration for any cement that may have extruded posteriorly. Insert the lateral tibial poly insert first. Verify the profile of the insert is directly on top of the profile of the tray. Do not impact the insert if the profile of the insert is overhanging the profile of the tibial tray. Impacting an insert that is improperly placed on the tibial tray may damage the locking mechanism of the insert. Tap the poly back and into place with a posterior impaction using a mallet. Once properly in place, the insert will be at a 3 to 5 degree angle, and there should be no more than a 2 to 3 mm gap anteriorly. Assemble the poly impactor tip onto the impactor handle. Place the impactor tip onto the anterior mating surface of the poly and impact the head of the impaction handle with a mallet. The force should impact the poly at a 45 to 60 degree angle and will produce a snap sensation as the poly locks into place. Visually confirm that the poly inserts are locked into place. There should be no gapping between the poly inserts and the tibial tray. Apply a layer of cement to the femur, filling holes and covering bone surface, while taking care not to apply cement on the posterior condyles. Add a layer of cement to the femoral implant, applying less cement posteriorly. This will aid in preventing posterior cement extrusion. Assemble the femoral impactor head with the impactor handle. Impact the femoral implant. Remove any residual extruded cement from around the implant. The tibial poly inserts will be locked into place prior to cementing the femur. Therefore, it is important to follow a cementing technique that allows for minimal cement extrusion while maximizing fixation. Bring the knee into extension and remove any residual extruded cement from around the implants. Thank you for reviewing the iTotal G2 surgical technique animation video. For further technical information or surgical training material, please contact a ConforMIS representative.